The topic I want to carry forward today about this really centers around the concept of inflammation. I mentioned the last video that the whole understanding of TMD revolves around the understanding of inflammation and what inflammation does within the temporomandibular joint and what inflammation does exterior to the temporomandibular joint. So there's a triad, 3 parts, to what I found out about TMD, and that the triad is involved with 3 things that are necessary to understand what's happening within the joint and how it gets there. So the first part of the triad is this, and this is learned in dental school. I think just about every dental school teaches you this. I'd be surprised if they don't. I was taught this in the early 70s at Indiana University, and that is how much load of the temporomandibular joint comes from the posterior teeth. And the answer is roughly 90% of the loads on the temporomandibular joint come from the posterior teeth. So you understand that the anterior teeth don't load the temporomandibular joint much, and the posterior teeth do. The second part about my understanding and how this all came to play out is this, and that's something that I didn't rely on the textbooks. I relied on my personal experience as an oral and maxillofacial surgeon over a period of 30 plus years. This was 10 years ago. 30 plus years of actually doing surgery on the temporomandibular joint. And whether I was doing open joint surgery, meaning making an incision in front of the ear and going into the joint and doing some mechanical, surgical, whatever within the joint, or whether it was through an arthroscope, each and every time I did surgery, and they were roughly a couple thousand surgeries, half through the scope and half open joint surgeries, I would take out a piece of tissue and send it to the pathologist. Standard operating procedure for a surgeon to, if you take something out, or even if you want to see what's going on, you take a piece of tissue and you send it to pathology. Literally 100% of the time when that pathology report came back, whether I took out the meniscus or I just clipped off a piece of some tissue through the scope, 100% of the time, the first line on the pathology report had something the pathologist had something to say about inflammation, chronic inflammation, inflammation present, but there was always a notation on the pathology report that there was chronic inflammation within the joint on that piece of tissue, 100% of the time. So from that, I deduced that if you had temporomandibular joint problems, there was inflammation in the joint. And then the second part of the triad was this, and that is how inflammation that we know is there 100% of the time, inflammation within the temporomandibular joint creates all these disparate symptoms. And I'll go through the litany again. Frequent and recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, feeling of fullness in the ears, subjective hearing problems, dizziness, vertigo, shoulder pain, arm, hand, finger tingling and numbness, and locking. That's the litany, and they're well accepted. Nobody wants to argue with those, except the arm, hand, finger tingling and numbness, which I kind of figured out independently. I don't think that's in the literature quite yet. But here's what it dawned on me after I got doing some thought experiments about this, after I found out how successful the device was. And that is this, and I didn't learn it out of the textbooks. Again, it was, as the proper word is, heuristic, H-E-U-R-I-S-T-I-C, heuristic information, trial and error. But I realized that something I learned from my orthopedic colleagues on my orthopedic rotation in my residency was actually in play here. And the orthopedic surgeons know all about this. They, and the dentists don't. So orthopedic surgeons know all about, in the vernacular, what they call joint splinting. having to do, in their case, the best example is tennis elbow. When you have an inflamed elbow, tennis elbow, the signal of that inflammation goes up the autonomic system to the central nervous system, and the central nervous system registers that there's inflammation within that joint. And the central nervous system says, hey, I'm going to give you a hand about this. Don't move that joint, and sends out another autonomic signal to the muscles, upper arm and lower arm, that move the joint, and says, tighten up. And the orthopedic surgeons know all about this because they talked about it years and years ago when I was a resident. And the pain from a tennis elbow does not come from the elbow itself. It comes from where the muscles are attached to the bone. And some of you may remember about how where the painful stimuli begin, it is where the muscles are attached to the bone. The nociceptors. Nociceptors are in the periosteum, and where the muscles are attached to the bone is where the nociceptors are then stimulated when the muscle tightens up and pulls on the periosteum, and it hurts. Now, if you disbelieve that or don't know about that already, that is why when you do your local anesthesia into the mouth, especially when you do a block, a mandibular block, when you go through the mucosa, patient doesn't respond. They won't pull back. But when that needle tip goes through and hits the medial aspect of the ramus of the mandible, just at one point, that's when they're going to respond and pull back. That's because that's where the nociceptors are on the periosteum. So this mechanism that the orthopedic surgeons have known forever, they call joint splinting, doesn't have anything to do with the temporomandibular joint. It has to do with all the other joints in the body. Well, that mechanism works for the temporomandibular joint. It's exactly where it works. This joint is just a joint like any other joint. And it's not so special that, like you learned in dental school, everybody talked about how special this joint was. No, it's not really special. It has different anatomical design to it, but it's a joint, just like any other joint. So when you include that understanding of that mechanism that the orthopedic surgeons know all about, called joint splinting, you then can, if you know your anatomy, your gross anatomy, then you can understand what happens with all these symptoms. And it's quite simple. When the joint becomes inflamed because of the three primary causes, which are bruxism, functional malocclusion, and trauma. All three of those cause either acute or chronic inflammation and chronic pain, acute or chronic trauma. So the inflammation then ends up within the temporomandibular joint, and the inflammation then sends a signal to the central nervous system. Central nervous system says, tighten up. And then all the muscles of mastication, of which I won't go through these, we can go through them later on. That'll probably be another edition of our presentations. But the patients will complain right there. They'll come in, doc, it hurts right there. Insertion of the temporalis muscle, or right here, the masseter, or right here, the mylohyoid, and it skips around from one side to the other, and they'll come in one day and they say it hurts here, and the next hurts here, and if they're talking to their PCP, the doctor looks at them, their eyes roll back, or the dentist, you look at it, it's like, I have no idea what's going on here. I'm a dentist, I'm not a physician. And it's like, this is unusual facial pain. Everybody kind of clamps it in that category, unusual facial pain. It's not unusual. It's like the muscles at various times under various circumstances are getting signals to tighten up, and then it hurts where the muscles pull on the bone, and they have headaches, extreme headaches that go on for 10, 20, 30 years, or jaw pain. And then the second most common symptom of actually behind headache is neck pain. And when this inflammation goes on for a length of time, whether it be several months or several years or several decades, eventually that signal keeps going up to the central nervous system saying, hey, I'm inflamed. I'm inflamed here. And central nervous system says, hey, buddy, I told you don't move the jaw. Now what I want you to do is hold the whole head still. Hold it still. And the muscles of the neck will tighten up, and the patients will come in and they go, doc, it hurts right there every morning, right where the sternal, well, they don't say sternocleidomastoid. They say right there, doc, every morning it hurts right there. Or the trapezius across the back, or here. And they will have neck pain. Now, the interesting thing that occurred actually many years ago, as I started to see hundreds and thousands of patients with this problem, is after a while, the inflammation continues. It's not treated for one reason or another, not diagnosed for one reason or another. And the signal goes, hey, I'm still inflamed. The central nervous system says, hey, I told you, don't move the jaw. Now I told you, don't move the whole head. Now what I want you to do is hold the whole shoulder girdle tight. Hold it all tight. And now the patients will complain of upper arm and shoulder pain. And because of what we call the strap muscles on the side of the neck, the scalene muscles in particular, they're strap muscles. They look like this on the side of the neck. And if you remember from your gross anatomy, because that was my, in dental school, that was one of my high points, learning gross anatomy. And through the scalene muscles come the brachial plexus. And when those muscles get the signal to tighten up, they tighten up and they squeeze the brachial plexus. And as you probably remember, the brachial plexus supplies sensation to the entire arm, hand, and fingers. And that is when the patients will come in and they will complain of arm, hand, finger tingling and numbness.